Hi everyone, this is Evan Wilson, the third year McMaster Radiology resident. Welcome to your next video as part of your McMaster Clinical Skills Radiology series. I wanted to make this video on abdominal radiograph views, the different views that we acquire when taking an abdominal radiograph. Mostly because I think it's an important concept to go over, but also in the spirit of keeping these videos nice and short. I didn't think that I could go over it at the same time as the video on pathologies. So I just made this short focus video just so we can go over this important concept when you're looking at abdominal radiographs. So what are the different views or techniques that we use when taking an abdominal radiograph? There's a few different common projections that we acquire. There's your standard supine projection where the patient's just laying flat on their back, and we take an anterior-posterior projection. There's the AP when the patient's upright, so they're actually sitting up straight, and we'll talk about why that's important. And then there's decubitus, which means laying on your side. It can be either the right side or the left side. And we'll also get into what we prefer. Usually we do left lateral decubitus and why that's important. And then we'll also talk about checking if the chest is included as part of the same series, specifically an upright chest, and why that's important as well. So why is knowing which view you're looking at an important concept? Well, certain pathologies depend on free air or air fluid levels in the abdomen. So free air being the air that's in the peritoneal cavity outside of the bowel loops, which can often indicate a perforation, or air fluid levels, which typically we look for within the bowel loops, although if there's fluid in the abdomen and free air in the peritoneal cavity, you can see them outside the bowel loops as well. But both of these concepts are important for identifying different pathologies on an abdominal radiograph, and how the image was acquired or which view we're looking at is important in our confidence in assessing for these things. So these air fluid levels or free air can really stand out or it can really hide, depending on either the patient positioning or the radiographic view that we acquired. So if we look at an upright or erect radiograph, this image on the top is just showing this patient upright, the floor is here, her head's going toward the ceiling. This is the X-ray tube. This is how we're shining the radiation through the patient. And the detector that's going to pick up that radiation to form the image is behind the patient here. If we actually look at the radiographic features that produces for us, if you have fluid settling dependently, any fluid is going to follow gravity and settle dependently. This cylinder is just kind of a analogy for the patient's bowel. So if you have fluid settling dependently with gravity there, you have air going antidependently, and we look at how this projects onto our film that we produce, we'll cut this edge. We're looking essentially parallel with this edge, and then we'll see that as a different density below, and then a hard edge, and then a different density, which is air, above. So the fluid below will be more dense, the air above will be less dense, and we'll see this line on our radiograph, which will form that air fluid level. So it's an important concept that we need to really be looking in parallel with that line of two different densities in order to see that level of density. And how does it actually look on a radiograph? Well, if we look at this upright or erect radiograph of the abdomen on the left side of the screen, this is kind of the real life or radiographic manifestation of what I was just trying to show on the prior slide. So we're looking in parallel with this line here, this fluid settling dependently in the bowel. Below that line, we're seeing more density or more white on the radiograph. Above that line, we're seeing the air density or more lucent or dark on the radiograph. And that edge itself is what's making up the air fluid level. And in this case, we can see multiple air fluid levels throughout the bowel. And then I know this on the left side of the screen, sorry, the right side of the screen, this is not an abdominal radiograph, but it just illustrates the same concept very well. So again, this is upright, so air will go antidependently. Any fluid, if present, will go dependently with gravity. So we look under the diaphragm here. Because the patient's upright, we're seeing this extra lucency underneath the diaphragm, which indicates that there's free air in the peritoneal cavity. If this patient wasn't upright, this air wouldn't have floated upwards to be below the diaphragm, and we wouldn't be seeing this line, and you wouldn't get as accurate of a diagnosis of pneumoperitoneum. If we look at a supine radiograph in contrast, so this patient's laying flat on their back, the X-ray tube is here, we're shining the radiation down, and the detector is behind the patient here. This is flipped up. I want to see what we're actually looking at when we look at the radiograph here. But again, this is analogous to the patient's bowel. So in this case, the patient's laying flat, any fluid within the bowel is going to settle dependently. Again, this is flipped up sideways, but this would be the dependent portion, the fluid settling down here. And then if we look at that, our radiation didn't cut through parallel with that edge. It just went straight through both interfaces. So we're not seeing a clear line between two different densities. This is just going to look as if it's one density because we're not seeing the contrast between the two. We're not cutting that edge in parallel. So, I mean, it can kind of be a difficult concept to wrap your head around when you're first looking at these, but we really need to see that interface between two densities in order to be confident that it's there. Otherwise, this is just going to appear as one density on our film, and we won't be able to see that air fluid level easily. So the question mark here indicates we're getting little information about this air fluid level being present because we did a supine film only. So again, if you take a look at both of these, and you look at either the presence or absence of air fluid levels, you can try to guess which is upright and which is supine. Or you can just look at the labels. These are often labeled so when you're reading them in clinical practice that you can actually see what the text did, so you can be more confident in what you're looking at. So this up arrow here means the direction the arrow is pointing is upright, so this is an erect film. And as you can see, the air fluid levels is the same image that we looked at on the prior example. So this is the upright erect film with the multiple air fluid levels, which, by the way, would indicate likely a pathology going on when you see this many air fluid levels. Particularly, you'd be thinking about obstruction. And then although this is a normal radiograph on this side, because it's supine, you couldn't be 100% confident that there aren't some air fluid levels hiding within this. If we look at our next view that we'll commonly see in an abdominal radiograph, we have our lateral decubitus. So the patient's laying on their side. They look kind of oblique in this diagram just because it's a little bit, I think, hard to illustrate. But really they're laying fully on their left side, and then you're going to shine the radiation through basically straight on through their abdomen with a detector behind them, but again with them fully on their left. So again, this cylinder is analogous to what would be going on in the patient's bowel if they're in that position. So their fluid again is settling dependently with gravity, and because we're shooting the radiation kind of directly parallel to how that fluid level would be settling, we would be looking across and we would see this abrupt change in density. So you have the fluid settling dependently, you have the air above it, and we're going directly parallel to that line. And again, how that's going to show up on the film, which is behind here, would be higher density below, lower density above, and a nice line between the two. Again, which is in contrast to the diagram we looked at for the supine radiograph, where we really weren't getting this information. So if you take a look at this, which position do you think this is? Well, you can see an air fluid level here. You can see an abrupt cutoff in density with more lucent air above it and more dense fluid below it. You can see the patient's lungs are up here, so this is toward the patient's head. And the patient's pelvis is down here, so that's more inferiorly. And then you can see this large organ here. So that's most likely going to be the liver. So it looks like this patient is in left lateral decubitus, and the interesting thing about this case is this large air fluid level doesn't look like it's probably in a bowel loop. It could be in a very dilated large bowel, but it's more likely this patient has a lot of intraperitoneal free fluid, and then they also have a lot of intraperitoneal free gas, which is settling or floating antidependently over the liver here. So that's a good example of a pathology on left lateral decubitus view. And one more point before we finish, just on the chest being included. The upright chest radiograph looking under the diaphragm is going to be your highest sensitivity for picking up pneumoperitoneum. So if you do have an abdominal series and you have an acute abdominal pathology that you're worried about clinically, it'll be very prudent to include an upright chest to increase your sensitivity picking up pneumoperitoneum. So that was the point on the upright chest radiograph as well. So in summary, we talked about the different views of the abdomen. We went over kind of how these views relate to what we're seeing in terms of air fluid levels and free air, what goes dependently and what floats antidependently, and really the concept of how we want to catch that edge between the two densities in parallel in order to see it, so it doesn't hide on us in the radiograph. So we talked about supine, upright, and decubitus views, and how it's important to include an upright chest if you're worried about an acute abdominal pathology. Thanks for watching, and we'll see you next time in our video of acute abdominal pathologies.